So amazing to listen to that. Oh my gosh, this is, I know how to use a mic. A warning, when I stand up, no, just turn it down. Anyway, we're going to continue on with diagnosis and studying of aortic valves and aortic disease. And this time, Dr. Alex Campbell is going to come up and do some speaking. And he's a general cardiologist, he says in his bio, but focusing today on aortic disease and associated thoracic aortic disease. And so please come up. Nice to meet you.
I didn't sleep last night very much. I was on call, and I was kind of thinking to myself on the way here, boy, I'm tired. And then I had to say, well, at least I'm not Amy Johnson. Wow. Could you, a few years ago when you walked to my office for the first time, would you have ever imagined that you would be just a few years later down doing this? Oh, the human spirit's alive and well. I met Amy and Pete a few years ago, and it's easy to kind of take credit and say, well, yeah, they're here because of all of our work, etc. But really, frankly, who saved Pete's life was his primary care doc, who used his stethoscope, right? And he's a really good primary care doc. Referred to us, and then our dialogue and our communication and understanding, where's Pete at? It's not everything is black and white in medicine. In fact, most things are not black and white. There's always shades of gray. So the communication between your primary care doc and us, and then when it's time to refer to Abbott, that is the difference, in my opinion, between kind of mediocre and excellent care. And I think I'm very proud of that. And your doc did a great job. Do I advance this or do you? How many people here know a lot about the heart? I just want to get a judge as far, because there's kind of some basic anatomy here, and I don't want to, are there people here that know tons about the valves, or is kind of starting from basic anatomy okay? All right, let's walk through the heart. The heart is basically a pump, and there's two pumps connected to the lungs. All right, so the beginning path for blood, in my opinion, comes in the veins. The veins, blood goes through the organs sucks out all the oxygen from metabolism, then it dumps it into the veins where it's low oxygen. It comes back to the right side of the heart. Is there a pointer in here? Yeah. Comes back to the right side of the heart, and the right side of the heart is kind of this flimsy little organ that pumps blood across, low oxygen blood, across the lungs, which is essentially an oxygenator, to another pump, which is the left side. Then the left side pumps it out to the body. So it's two pumps in series with an oxygenator. And there's 4 valves along the way that keep blood going in the right way. If there weren't, and they're one-way valves essentially, if there weren't any valves in the heart, blood would just kind of slosh around and not go anywhere. So that keeps blood moving forward in the right direction. Most valve disease occurs on the left side of the heart for various reasons, because the pressure on the right side is very low. The lungs are very low pressure. The arteries in the heart and your body are very high pressure. So we see most valve disease occurring on the left side. When the heart relaxes, blood goes from the lungs into the heart. It goes through the mitral valve, okay? The heart squeezes, the mitral valve shuts, preventing blood from going right back up into the lungs, and it squirts it up into the aorta, which you've just heard all about. Between the heart and the aorta, there's an aortic valve, which is basically just a one-way door that lets blood go out, and then when the heart relaxes, it shuts, preventing blood from going right back in. If there's no aortic valve, blood would just go up and down and up and down. All right. So this is what the aortic valve looks like. We hear the terms trileaflet or tricuspid. That's because there's 3 leaflets or 3 cusps. If you look at that thing in cross-section down the barrel, that's what it looks like. It's open and it's closed. The fascinating thing about this valve is this is it in kind of gross anatomy. It's not necessarily what the valve looks like, but look at the scale. That's a centimeter. These leaflets are less than a millimeter thick, and they go up on 100,000 times a day, every day. Sorry, I didn't hear too much caffeine. How do we go back? Can we go back a few? No. So this is, when we talk about echoes, this is kind of the view that we look at. An echo is just a fancy term for an ultrasound that we use in medicine. You see the gross anatomy, that's the same thing here, closed, open here. This is what we look at when you do that thing that's on that a lot of you have had, echocardiograms. This is the pictures we see. This is important, and this picture kind of establishes the connection between aortic valve and the aorta. The aortic valve is not just some barrier between the heart and the aorta. Can you go back 2 slides, please? That picture is a microscopic view of this part right here. Okay, so we're going to see there's a chunk of heart muscle, there's a chunk of aorta, and then there's an aortic valve leaflet. And this is what it is. So there's your heart muscle, there's your aorta, and there's your valve leaflet. Look at how thin that thing is. It's amazing how durable this is. But when you really trace it out, the aorta comes down and forms that valve. It forms 3 leaflets, so there's not a difference between the aortic valve and the aorta. It's part of the same thing, and that's why patients with abnormal aortas have abnormal aortic valves, are more likely to. Conversely, patients with abnormal aortic valves are much more likely to have aortic disease because they're kind of the same thing. They're not part of the heart muscle. Oh, sorry, can you go back one? All right. So the heart beats 100,000 times a day. And when you think of what that valve does and how thin that valve is, I mean, it's less than a millimeter thick, 100,000 times a day, being hammered down by your blood pressure. Again, the heart squeezes, pushes blood up into the aorta. The pressure slams that thing back down. So 100,000 times a day, that's about 30 million times a year. By the time Pete was at age 38 when he got his aorta done a few years ago, it's by the time somebody's 40, that valve opens and closes 1 trillion times. And it's less than a millimeter thick, being hammered down by all this pressure. It's pretty amazing, right? So what can happen over time is the wear and tear on that aortic valve. It can become rusty. It's not really rust. It's actually calcification that has nothing to do with your dietary calcium. It just happens when you get wear and tear on anything in your body. It's like arthritis in your joints. You get calcium crystals. When that valve bangs, opens, and closes, it gets calcified. And that's what you're seeing here. This is what happens to valves over the time. They get these chunky little things. Contrast that to that nice, beautiful valve that we saw a couple slides back. So when an aortic valve gets rusty, as I say, 2 things can happen. Either it can have a problem opening or it can have a problem closing. And this is what we see here. So this is the normal valve, closed, open. When it gets rusty and narrowed, we call it stenosis. We have to say things fancy in medicine so we sound smart. It's really just narrowing. It has a hard time opening, it gets narrow. Conversely, this thing opens okay, but it has a hard time narrowing, and this will cause leakage, so insufficiency. So rusty valves can cause that to happen. In the world, besides, there are genetic abnormalities of the aortic valve, but in reality, there's 3 conditions that cause abnormal aortic valves. Again, the valve opens and closes so many times over your life. It's very common for people's, the aortic valve is the most common valve we have to replace over time, and it's very common to have it become narrow and need to be fixed maybe in 70s, 80s, 90s. That's very common. So what Pete knows very well about is this thing. So remember I said there are 3 aortic cusps? This is what a bicuspid aortic valve. So instead of tricuspid or trileaflet, there's 2. We see, as we heard, there's some people say 1%, some people say 2%, but it's the most common congenital abnormality of the heart is this disease. So why do people, and this is the most common cause of needing an aortic valve replaced before the age of 60. If you see somebody with a very narrow aortic valve in their 70s, 80s, 90s, it's probably just run-of-the-mill wear and tear in that valve. Somebody comes in 40s, 50s, 60s, they need an aortic valve. Most likely it's this. Why? Well, because instead of that valve closing, right, there's 3 closure planes. All that force is distributed on that. Now, you have it distributed across 2. That puts a lot more wear and tear instead of 3. So we see people typically in their 40s, 50s, 60s with this type of valve that either get narrow or leak, sometimes a lot earlier. Talk about this. Oh, and also I forgot to say, in developing countries, not so much in the United States, so the 3 types of valve disease that need to be fixed. Number 1, run-of-the-mill degenerative, what we call aortic narrowing. Number 2, bicuspid. And then 3rd is rheumatic. Have you guys heard of rheumatic valve disease? The reason we treat strep throat in the United States is to prevent rheumatic fever. When you have a strep bacterial infection in your throat, your body has this kind of wicked immune response, and it attacks your valves. So the reason we treat strep throat in developed countries is to prevent rheumatic fever, and we don't see that much in the United States. So I was hoping Dr. Askew would be here. He's the surgeon. I'm the general contractor. He's the carpenter of our team. But this is, and there are, like the aorta, unlike the aorta, in the aorta there are some medications that we can use to slow the growth. There's, with aortic valve narrowing or leakage, there's nothing that's been proven. It's a mechanical thing. So like your car, if you have an abnormal valve, you need to remove it and put in a new valve. And I can talk about some of the new technologies. I'm on the valve team at Abbott, and we have really cutting-edge technologies that I'm sure you've all heard about. So I guess the approach. So when Pete came into my office and said, okay, well, you got a valve issue, I think the things that are important are determining when that valve becomes severe, because we never, well, hardly ever, unless you're doing heart surgery for something else, we only replace severe valves. You would never go open a heart and remove a valve just because it's moderately narrowed. You have to wait until it's severe. And we have criteria mainly on echo to judge that. So I see a lot of people that follow kind of moderate, severe valve disease follow along and kind of give ideas give people education on what the symptoms are. But when the valve hits severe, that doesn't mean ding, 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 we have to replace it. You would think maybe you should, but the name of the game, and I'll talk why, is you want to put off doing surgery as long as you can. So the two things we look at once somebody's valve becomes severe, and this is either leakage or narrowing, it doesn't matter. The first thing we look at is the patient having symptoms, and we'll talk about what the symptoms are. This is kind of a classic picture from almost back in the DeBakey era, where they follow patients, these were bicuspid valves, these are the years, and back as happens with bicuspids, they do fine, and this is the time where they kind of develop, around their 40s or 50s, severe disease. So some develop severe disease here, some here, but they all kind of do pretty well until they develop symptoms, and then look what happens to survival. It's actually worse than pancreatic cancer, the mortality, once you have real deal severe symptoms. What are the symptoms of severe valve narrowing? Well, when you think of what the heart does, it's a pump that takes blood from the lungs, pumps it to your body, and it pumps it up into a hose. So think about putting your thumb over a garden hose, having a pump up to it. It slowly puts pressure on that pump, and that pressure gets transmitted back to the lungs. And then the pressure that increases inside your lungs causes shortness of breath. So the hallmark feature of either valve narrowing or leakage is shortness of breath. And it's usually exertional. It's not usually just sitting around. But here's the key, and this is what goes back to the communication, is it's not like, you wake up one day and have shortness of breath. It's not like a heart attack, or it's not like a dissection where you get crushing pain and it's sudden. It's a whole different animal. This develops over decades. So understanding that your thumb is slowly going that hose over years and years and years, you're not going to expect to just wake up one morning and be short of breath. So yeah, call me, Pete, when you're short of breath. That's not how it works. The usual thing is, well, okay, now you have severe valve disease. How are you doing? Well, great. How far could you bike 2 years ago? I could bike 20 miles. Can you still bike 20 miles? Perfect. Keep biking 20 miles. We'll see you back in 6 months or a year. How are you doing? Well, I get short of breath after 15 miles. Okay. That's where you start. With Pete, it was can he still playing Mustang Sally on the drums, and he could do that, and then one time he couldn't, and it was time. But there's a lot of misunderstanding that shortness of breath is this slow progressive thing. So it's the patient features that we need to talk about. Then my job is looking at setting up a screening program once somebody has severe aortic valve disease or moderate valve disease, and saying, okay, if you're not having symptoms, and I work in the western suburbs where there's a lot of Germanic and Scandinavian farmers that just they can come with their foot cut off and say, yeah, it kind of hurts a little bit, so they just don't complain. So sometimes we have to put people on a treadmill and say, really push them until you fatigue and until you can't go anymore. And if they only go 2 minutes, they're clearly limited. So there are some tricks we have up our sleeve to really tell, are they limited, if you think that somebody's being kind of stubborn. Then, besides the symptoms, this is the two effects that we look for. Again, understanding if the valve disease is starting to hurt the heart, it's time to fix it. So as long as you're not having symptoms, and as long as it's not hurting the heart, We can wait years and years. I follow people for years with this. But that's my job then, is to understand when it's starting to hurt the heart. And what we look for is, again, it puts a lot of pressure on the heart. It's like the part doing bicep curls every day. It starts to thicken and starts to get stiff. And if your biceps get big, that might be a good thing. But if your heart gets big, it's a really bad thing. It gets stiff and it starts to fibrose. And the second thing that it can do, especially if your heart's leaking, is it causes a dilated heart and the heart function drops. So these are the things that we're looking for when we're following you. All right, so once it's time and we set up the screening program and Pete says either, well, I'm getting more short of breath, I think I might be not feeling as well as I did last time I saw you, either 6 months or a year ago, or I say, the heart's starting to get a little wear and tear, it's time to do this, then we have to start talking about valve replacement. And I'll talk about TAVR. I'm sure many of you in here know about TAVR. I'll give you the most contemporary data on TAVR that we have to date. But this is still nationwide by far the most common way to do this. And I know a lot of you in here know about valves. I'm sure a lot of you have artificial valves, but I break them into two types, metal and tissue. Tissue valves, you don't need a blood thinner. They last 10 to 15 years, probably the more new ones, about 15 years we get out of them, but you don't need a blood thinner. The metal ones have a loud click. And you need to be on warfarin and Coumadin. You can't be on one of the new ones you see on TV that are more convenient. It has to be for a very specific reason, Coumadin and warfarin, which is fine, but that's a life. You put a metal valve in somebody, it changes their life. Coumadin for the rest of their life does. So it's a really, really big deal. It's not trivial. And also, you'd be surprised how many dairy farmers that come and say, can I just use my pig's heart? You can't. There's a very specific fixating process with the valve that makes it immune to your immune system and lets it last longer. So it used to be kind of dogma that about age 60 was the cutoff. And this is always, like I said, there's always gray. It's absolutely patient and physician specific. But around age 60, below that, we really start thinking, we should use a metal valve. And that's because, think about it, and that has changed in the era of TAVR big time. But before the era of TAVR, if you say put a tissue valve in a 30-year-old, okay, and here's the paradox. The younger you put a tissue valve in, the less long it lasts. So you put a tissue valve in a 30-year-old, it might only last 6 years, because the younger you are, the stronger your immune response is, and it chews up valves a lot quicker. You put a tissue valve in an 80-year-old, it might last 20 years. It's kind of the wicked paradox. But if you put a tissue valve in a 30-year-old, and then by age 40, you're going to have to fix it because it either leaks or gets narrow. Well, you have to open the chest up, remove it, shut up, and then maybe at age 50, do that again. Every time you do that, that causes scarring in the chest, and it significantly increases the risk of that surgery. Plus, many of you in here know that's a huge thing to have, right? It's a big, big, big deal to have your chest open. So traditionally, it's been under age 60, we really consider metal valve, unless there's something, I've had pro hockey players or skiers that really don't want to be on blood thinners, so we say, okay, as long as you know the risks. And then over age 60, because after age 60, it's about 15 years for valves, so then at age 75, then maybe we'll just have to do one more replacement. This is what it looks like. You get a valve, the chest is open, tons of strings. Busy, take off the aorta. If the aorta is enlarged when you're doing this procedure, you fix the aorta as well. But you cut off the aorta, cut out the old valve, put the new one in, put a bunch of sutures in, put this together, and close the chest. How many people in here have had valve replacements? Wow. How many people have had their total chest open? So actually, if I'm wrong about this, this is, for those of you who haven't, I have a little spiel before patients go, and it'd be interesting to see if you guys knew what you're getting yourself into or knew how big of a deal it was, especially that first month after. So usually what I tell people before, and I have a spiel, and I hate to use the C word, but it's kind of like for that first month having cancer. Opening the chest, removing things, suturing in, it's probably the most inflammatory thing to your body in terms of inflammation that you can ever imagine. It's just wickedly inflammatory while all this stuff's healing. And it's really common to have night sweats and fevers and chills and poor appetite and just kind of feel like you got the flu for a few weeks. It's very, very common. So I tell people that up front, like you're going to feel horrible for a few weeks, maybe, hopefully not, but and then I usually like to see people about a month after, and usually I know they're going to come in and say, why did you have me do this? I feel terrible. And that's when I give them about that 4-week, a little pep talk saying, you're almost out of the woods. You got this. Give it a couple more weeks, because in my experience, and it'd be interesting after to talk to some of you guys, between 4 to 6 weeks is a lot of times where people turn the corner. And it's because the inside of your chest heals at about 4 to 6 weeks. So the inflammation on the inside's done, and then you're just waiting for the sternum to heal. The sternum it's collagen, it's very low vasculature, so it takes 3 months to heal versus what the 1 month on the inside. So then after that 3 months, the interesting thing about valve disease, unlike a heart attack or like a dissection where it's very sudden and very profound, this happens over time. Again, people just kind of slow down and say, well, I could ride my bike 3 miles last year, maybe 2.5 this year, I'm 1 year older, and then I'm down to 2. So they kind of compensate for the fact that your heart's really doing a ton of work cranking out against that valve. So we see people at a month, say, give them the pep talks, and you're going to get through this. And then about 3 months, in my experience, people are kind of back to about where they were before surgery. And the cool thing, especially with really bad valve disease, is then over the next year or so, people will become reconditioned to having a normal valve and not working against that for the last decade. And after that next year, a lot of people come back and say, whoa, I've not felt this good in a long time. It'd be interesting to talk to some of you guys, but that's been my experience. TAVR. So TAVR the acronym is Transcatheter Aortic Valve Replacement, TAVR. A catheter is just, it's a hose we put inside a blood vessel or an artery so we can insert and take things out. So transcatheter aortic valve replacement. The most common way we do this, we go into the femoral artery. Why the femoral? Because it's the biggest. It's pretty big. Put a big catheter in there, crimp up a valve, come up around the aorta, go through the valve. We usually do this for 95% for narrow valves, but you can for leaky. It just doesn't work as well. And not for bicuspid. We'll talk about this, at least not right now. You put it across, and then you simply crimp the old valve to the side, and the new one deploys, remove the balloon, pull everything out, and you got a new valve. At Abbott, probably 70% of our valves are doing now is through this. Of those, 90% are conscious sedation. You go home in 2 days, so it's basically having a colonoscopy and you get your heart valve replaced. I mean, that's incredible, right? The story, I graduated from fellowship when I was in 2013 at the U of M, and these just were marketed. It's actually a really interesting story. Way before TAVR, so back like around 2000, 2010, we used to do balloon valvuloplasties for people, and we'd call it palliative. What does palliative mean? It means we're not really looking long term, we're just trying to make you feel better for 6 months or so, understanding that this is making you feel better, it's not going to make you live longer. Well, then I said, well, if we can put a balloon across that valve and open it up, why can't we like crinch a valve on there and do that? But it was thought to be crazy. Well, you're gonna blast apart all this calcium here, you're gonna shower it up to the brain, you're gonna make everybody stroke out, right? So the first trials of TAVR were probably from about 2005, 2010, and they were done in very sick, very old people with calcific, just the regular valve disease. A lot of people in their 80s, 90s with comorbidities. Comorbidities means you either have lung disease, kidney disease, liver disease, something bad or stroke that increases your risk for surgery. Every time somebody goes to surgery, we calculate what's called an STS. It's the Society of Thoracic Surgeons risk score, which basically very clearly tells you your risk of dying or having something bad happen in the surgery. And we can place people in the low, intermediate, or high risk. Or prohibitive. Prohibitive would be somebody who's really, really sick that they're not going to make it off the operating table. So those patients back around 2005 said, well, why don't we try, since they don't have an option anyway, to do TAVR on the sickest of the sick, because we're never going to do it in somebody who's healthy because it's not the standard of care. Well, in those patients, at 1 year, with medical management, I just said there's no medical management, with severe valve disease, the medically managed, about 90% were dead, whereas about 20% were dead with the TAVR. So people said, whoa, that's not many things in medicine will take your mortality from 80% to 20%. And I said, well, why don't we just randomize not just prohibitive risk, but high-risk people? And we operate in high-risk people all the time. It's not, we do it a lot. So we started enrolling people, not we, but, our center, and a whole bunch of else around the world, flip a coin. You either get a surgical or a TAVR. And it's called the Partner Trial, was published right when I graduated in 2013 from fellowship. And it was not just equal, but there's a signal that in really high-risk people, TAVR might be better. It's like, whoa, that's interesting. But again, this is not bicuspid. So I start lowering the bar. I said, okay, and to do this, you have to have a valve team of surgeons, and we meet every Thursday morning, surgeons, imagers, and talk and say, okay, is this person a candidate? And then intermediate risk, starting maybe about 2012, thousands of people in each group flip a coin. If patients wanted to accept that, flip a coin, and you either get a TAVR or a valve. Well, that study was published 2 years ago, and actually the signal in the intermediate risk patients were if you did it through the femoral, it's called transfemoral, if you did it through the groin, people did a little better, they had less strokes, and we now have data going, it just was published last week, 6 years of TAVR. That's the average length we followed patients. They look like they're doing better than aortic valves. I don't want to say that too, but there's a signal that there's something, probably because there's no sewing ring on it. So that's that's encouraging. Now we're enrolling at Abbott low-risk people. So not bicuspids yet. There's a separate trial I'll tell you about. But if you have a run-of-the-mill valve disease, and say you're a 70-year-old golfer, not many other medical problems, the gold standard traditionally is open surgery. Now you can come to one of our centers, flip a coin, and get either TAVR or surgery. And I think TAVR is going to end up being better. When you see these, I do the imaging for them. I don't do this procedure, but I'm sitting there, guiding the imaging. The patient's awake. And in here, so you don't have general anesthesia, they don't have thoracotomy, and they're not like in the ICU. They're awake. You do their valve. They go to the floor. How you doing? Maybe wait a day or two, and then they're home. It's really amazing. So that's where we're at, and I think probably within 10 years, surgical aortic valves will be, except for very young, will be a thing of the past. Pete couldn't get one of these because, well, he's really healthy otherwise, and I hope it's okay that I'm talking about this. Okay. Pete couldn't get one, first of all, because he has a bicuspid, plus he's too healthy and pretty darn young. So but now the paradigm, remember I said that 60-year-old age mark used to be kind of dogma, it's shifted down because we're doing now tons of what's called valves and valves. So now Pete has a surgical valve, or somebody, if you were 50 and somebody puts a surgical valve in you, it's bioprosthetic, we can down the road go in with a TAVR and put a valve through that valve, or even a valve through the valve through the valve, or see where I'm going with this. That obviates the need for repeat open chest down the road, so we're actually now shifting that bar down so people don't have to be on warfarin for the rest of their life. And I think that's fascinating. The way that we can do TAVR, the preferred is transfemoral, where you go in the femoral. You need to get into a big artery to get these catheters are here. The catheters are about the size of like a big magic marker. So you can either go here. You can actually puncture. This is sort of a TAVR. You puncture a hole right in the apex of the heart. We do them in the carotids sometimes. We do them in the brachial artery. But the preferred is down here that has the least complications. But this is the most important thing, and a heart valve team is, any center who does TAVR has to have a heart valve team, and every patient who gets a TAVR, you have research coordinators, you have people like Kevin who are experts, and people like me who are imagers, and surgeons, and the guys who do the TAVRs, and we all present every patient and scrutinize, is this the right thing to do or not? And there's a lot of dialogue. No, this doesn't seem like the right thing to do, and I would actually, circling back full circle, having primary care docs who use their stethoscope and refer. It's an integrated effort, and I'm proud to be part of it. So, sorry if I was talking fast. I was trying to talk for Judah. He was supposed to be here. I'm assuming he's fixing somebody's aorta at Abbott. But so, thank you, guys.
I have a St. Jude mechanical valve, and it is interesting to live with. And being a singer, I call it my kick drum. And believe me, listening to a wave to sleep rather than my valve is really a nice way to go to sleep. Waking up when you're having a nightmare is going to happen because that sucker goes, and now you're up. So it definitely is an interesting, it's 12 years, you guys, and it's an interesting thing to live with. Oh, yeah! Thanks to my team.